Good morning, everyone. Welcome back. I'm losing my voice a little bit this morning. So hopefully, I'm just going to go back through what we covered yesterday with a little summary. So we heard first from Laura Anderson from WHO GMP about their WHO perspective on measuring surveillance data quality, the challenges and the solutions for that. There's the WHO Surveillance Assessment Toolkit, which she introduced, that is now being rolled out across the world, and there's some pilots going to happen in this region. She's presented some examples of surveillance data quality issues and their impact on national program activities and planning. And then the data quality assessment tool within that toolkit was also discussed. And just to mention that our SRWG have agreed to support the rollout of this surveillance assessment toolkit and to support countries in using it, countries that are interested to do so. We heard from Molly Robertson from the Global Fund. She talked about the upcoming Global Fund funding request, which would be for funding from 2024. She mentioned what can be included in those funding requests for malaria. So building capacity for data quality generation, analysis and use at national and subnational levels is specifically mentioned in what you can request money for, and things including introduction of additional relevant data sets, which can include things like village lists and strengthening location data, health facility lists, etc. So it goes beyond just the malaria data. Mapping of subnational continuous quality improvement and activities to address data quality issues is a specific thing you can request money for. So this is new. You can request for activities to address data gaps as well, and also for short and long-term capacity building. And that can include also bringing in specific partners or a request for partners and a budget for those partners to contribute training and technical support. And for the RSSH component, so the health system strengthening part, it also included a specific component for national data quality review and improvement plans and capacity building and data analysis and use. So the countries are all going to have one-on-one workshops with Global Fund when the letters have been issued, but this is a lot of exciting information that's very relevant to this meeting. We then had breakout groups. We talked about data quality challenges across the region. So we covered the 6 dimensions across 4 different data types, and we split into 5 groups. A wide range of challenges were identified, and each group narrowed it down to the 3 top challenges. And some strong themes that came out were particularly for case data across all dimensions. There were different challenges, especially completeness and timeliness. And for non-disease data, there was a lot of discussion about health facility data and village lists being incomplete and the accuracy of those sorts of data. And across the 5 different groups, we have the table. We've captured all the information that everyone contributed. So every single post-it note we have, that's all being collated together, and we're going to put it back into a report, which you'll all receive back. Hannah Edwards from RBM Malaria Consortium talked about Surveillance Practice and Data Quality Committee, the RBM SMERG committee, and the Systematic Tracker Implementing Partner Questionnaire. And this is to share information about an improved coordination of surveillance and data quality improvement initiatives across the world. We encourage people to use it. There's a dashboard that you can then see all the results from all the different organizations. Sections of this questionnaire include case surveillance, data quality, data to action, and governance. There's the QR code again, if people haven't already used it. We will be sharing these slides as well. And then Elijah Phillip from CHI talked about identifying and addressing data quality issues, why data quality is important, how CHI works with national programs to understand and address data quality gaps, some country-specific examples from Laos and Vietnam. In Laos, talking about midterm reviewed surveillance assessment data quality, and in Vietnam, data review meetings. And finally, you very kindly gave us feedback on the APMEN SRWG activities to date and some great suggestions for things going forwards. So we'd had a voting exercise on the research priorities, and I presented back the results yesterday. And then we got your feedback through Mentimeter on Tech Talks newsletter training. And then we have lots of good ideas that we're going to take forwards into the next couple of years. Thank you. So today, we're really excited to hear from national programs. So we have 7 talks to hear from your perspective. It includes the data quality theme, because that's the theme of the meeting. And we've encouraged each country to speak about what they would like to talk about around this theme, particularly high quality data for targeted surveillance and interventions. And countries are transitioning in different stages, moving towards elimination, and the granularity and detail in that data changes as you move through those stages. So we're going to hear from different countries at different parts of that continuum. And then we'll have a coffee break, but it'll be halfway through. We've moved it to 10:30. So we'll have 3 talks and then coffee break. And then we'll have the other 4 talks. The future of SRWG, we've already covered that. So in the interest of time, that will be very short. And we have some closing remarks at the end, followed by lunch at 12. Okay, thank you.
Thank you, Professor Richard. So next will be our speaker. I would like to invite Dr. Gyabupapon to be the first presenter of today. She's a Director General of the NM from Lao PTR.
Good morning, everyone. My name is Gyabupapon Jindamongsa, Deputy Director from National Malaria Control Program. Today, I would like to present about the certification in my country. I would like to share our experience to one participant. Our background, the first certification is the project of diving the country into the database on malaria risk. And second, recommendation from WHO in order to target intervention package according to malaria epidemiology. We start certification in my country first in 1997 over subsequent certification exercise method have inborn the data quality improve. Look at the table. We start 1997 to 2008. We use the survey data, and then 2012 to 2015 we use the national malaria report, and then 2017 until now we conduct the data from DHS2 and conduct the spectrum modeling data from 2015 to 2022, and we assign the case assigned to the village health facility catchment area in 2022. This is process from certification overview to analyze it. In 2022, the stratification, we have the technique working group, have the SIMPE, WSO, and CHAI. We work together to analyze the data from stratification, and we final result in April 2022. For our result, like we have the reprogramming, have the plan, and submit to grant for in 2024 and 2026. This is data extraction and data cleaning. Before we analyze it, we look at the two data. The first, extraction data we conduct past 3 years from 2019 to 2021, and we conduct from the DHS2, because DHS2 we have the data all level support in the system, and our routine for the system we really strong, and then we plus the data from RAI, like they have the indicator they validate every 6 months, and follow data extract for the health facility. For example, the total case, total test, and conduct the report completeness, GPS coordinate, and population also. But for data, the cleaning follow the facility, but exclude the overlap. We look at the data from paper from the system. We avoid the overlap into data from the hospital, from the police hospital or military hospital also. And the case report follow the facility reassigned to the health facility catchment area. The data from provincial and district hospital or military hospital or PPM or active case detection outbreak response. We saw the patient. If patient depend on that village, we refer the patient to that village to calculate the by population, the number of cases we calculate by population in that area to avoid the overlap. About the mapping of case by village to reassign to health center, to health facility. 2022 stratification exercise, the first to assign the case to residential, the health facility catchment area, and then facility report. If case were not report, this is to health center. This is like a challenge for us, and this was important the data cleaning step for the sentence type of health facility and report. Look at the provincial, district hospital, military hospital, public, private mix, and active case detection outbreak response also. This is not reflecting the geographic distribution of case. And then the DHS2 does not include the on village under its health facility catchment area, but does not include the GPS coordinate of the residential village of the case. Case were mapped by residential village and reassigned to the close, like a next door of health facility catchment area. Can see the next slide for the example about the mapping exercise. And then the total of more than 5,000 cases were reassigned, and with 40% of the total 13,000 case report in 2019, 2021. Therefore, there is important data cleaning step. This is map to show the case resident in the village, in the district. The data case from the active case detection or military hospital or passive case detection and PPM also. This is the case from resident. About the applying risk model to analyze data gap. The data for the from health facility catchment area. Some health facility like no test or report a little bit and not sorry. And yes, with little or no testing or with substandard report, competent is not enough to rely on the total case number. This makes stratification of this health facility is challenge for us. And then applying this model to the area can help the program to design like the list of malaria, that area, this list of malaria or not. We can classify. And then the malaria Atlas project develop the list model for the Lao to complement the primary method using the raw epi data. The list model able to estimate malaria list, the predict case number across country based on underlying the malaria transmission potential and report the case number, and the total of 70 health facility is poor data, like a report less than 50% and the test less than 10 per year. And then 47 have the GPS coordinate, the map predictive model data. We use the generate case number. Also 76 this not have GPS coordinate, and the mean number of case into the district where we use the case number also. Our list map. The list map show the total medium overage case per pixel predict by the model. One pixel is about 810,000 how to say the megalit. In another word, a little small than 1 kilometer. The case data used the in model is biased toward where people live and report. Is it not successfully and the same location where transmission occurred? Therefore, the spectral model try to account this by taking into account the environment such as rainfall or temperature or distance. Yeah, and then you can see the form the list map malaria. Now the malaria in Lao, the malaria case is go down, but have the case in the south provinces in Lao PDR. About the data validation, look at this table. We have the 4 stratum, and previous we done for stratification in 2019, and then we re-stratification again in 2022. Every 2 years, we set up the stratification, and we can see in 2019, we have the 45 health facility in stratum 1 and 5 health facility in stratum 1, 2, and 12 health facility stratum 2, but we revise by TWG technique working group. We have the reason why we change the stratum 1 to stratum 2 to stratum 3. We look at the case and nearly the health facility previous stratum 1 like a free malaria, but in 2022 they have the case, or next door have the case, or nearly health facility have the case, and then TWG decide to stratum 2 and 3. Estimate the health facility population. We use number of population when we have the LAN campaign. We provide the long estimate and we use the population and then not only population in the we provide LAN. We use the map estimate population also. And in 2019, we used the stratification population with 1.45% crowd of the 3 year. 3 resort, we use the number of population, and finally, finally in 2022, we have the analyze it, and the result is complete. We classify the method to 2 areas. The first area stratified by district. If API less than 1, we call eliminate area. If API more than 1, we call burden reduction. And then for the strata, we stratify by health facility. Strata 1, no malaria, no case. And strata 2, low risk, it means the number of cases less than 5. And strata 3, medium risk, the number of cases are 5 to 20. And strata 4, we call the high risk, and the case more than 20. We clarify the 2 areas. First area, the elimination area, and second, the burden reduction area. The green color is elimination area. The burden is red color. Look at the map. The total burden reduction now 14 districts, and in elimination area we have the 134 districts in the 2022. And health facility catchment area find on the result. According to we set up the strata econ 1, 2, 3, and 4, and we compare to the population in 2019 and 2022, and finally from 2019 to 2022 the health facility change, like increase the 97 health facility, and then number of population increase also, but strata 2 and 3 not change for the health facility and number of population. And strata 4 is a high risk, and health facility like from 2019 more than 100, and for 2022 decreased only 88. Also population is decreased also. This slide to show the provincial have the starter. 11 province have the starter one, and 1 province no starter one. This is a health facility, a starter map. According to starter, this is number of health facility, and we mark the map. You can see the starter 3 and 4, orange color and red color in the southern part of Laos, and in the north, green color is mean the no malaria and low risk malaria. This slide to show the case from 2019 and 2022. You can see the case review from 2019 and 2020, but 2021, 2023, the case increased way back, but PF decreased. And January to June 2022 is low than January in 2019, but 2021 is high than 20. Yeah. Okay. This map at subnational level. You look at this is by district. This is the case listed in the district level, and we can analyze to the village resident also. Yes, this is southern part of Laos, Salavan province and Attapur province. Also the case we analyze and add by district. Yes. And we have intervention package according to starter 1, starter 2. We have testing and treatment, also the IEC. For starter 3 and 4, we have the activity like a package. If that area we call starter 3 and 4, we provide material or tool or medicine, anything to that area to service the patient come to the like we call the PCD. This is the intervention package according in 2022, and look at 6 province. We have the starter 3 and 4, and intervention package. We the National Malaria Control Program set up like a package to that area. Our summary in 2022, the district data 14 burden reduction. We have the 148 district in Lao PDR. Like if compared to 2019, we have the 23 burden reduction, but now 2022 decreased to 14. And for the starter 2019 and 2022, 97 malaria free, and starter 2 and 3 number similar, not change, and then 97 less than starter 4 case. Following review the final data of the map modeling group, there were some change made to the health facilities data. Data update in 2022, we reprogramming and modify the forecasting and plan to the green the right for plan, and then we update the burden reduction guideline. So now this is my presentation. Thank you so much for attention.
Thank you very much, Dr. Gabul Papon from Simpei Lao PDR. Next speaker is Dr. Tam Jane Chung from MOH Malaysia. So he's online. Dr. Tam.
Hi everyone.
Hello.
I would like to share my screen.
Thank you.
Is my screen available at the moment? Can everyone see my screen?
Yes, we can see it.
Thank you very much. First of all, good morning to Prof. Richard and everyone in Bangkok. My name is Dr. Tam. First of all, we would like to express our sincere appreciation for inviting Malaysia to participate in the APMEN meeting. And we'd like to extend our humble apologies for not being able to be there physically due to commitments here in Malaysia, because the program is planning for a lot of events in 2023. So we can't fly over to Bangkok to join everyone. Hope to see everyone next year. So we were actually asked by the Secretariat to present not only on high quality data targeting surveillance intervention, but a little bit on our current genetic malaria. So it's a bit challenging. I will try to cover everything within the 20 minutes. This is the outline of the presentation today. So we will talk about certification, a little bit epidemiology of malaria in Malaysia, whereby we have both human and genetic malaria, and also how we certify them, and what are the little bit about control measures that are done currently for both human as well as genetic. To start off, a little bit about myself. Coming next month in 2023, especially, it will be 10 years of me being a public health physician. And my first assignment is actually to work in a state called Sabah. In Malaysia, we consist of two areas. One is Peninsula Malaysia, one is Borneo. And most of our zoonotic malaria cases burdens are in the Borneo part of Malaysia. And I'm assigned to a place called Kinabatangan, whereby we have the second longest river in Malaysia, Kinabatangan. So I have to take care of the entire two huge districts in Sabah. So it's actually very famous for the pygmy elephant and orang utan, and that's where I get my initial experience of spending the there. And the graph below is actually mentioning about the trends of malaria in Malaysia for the human cases that have been slowly declining. And as the development of our capacity, we start to detect genetic malaria as well. And I would elaborate further later. So, in general introduction of our malaria program in Malaysia, for the past decade, it has been a very interesting journey for Malaysia. So, initially, we were having the control phases whereby we have SPR less than 5% of fever cases, and we actually detect and treat them. And by 2011, Malaysia enters the pre-elimination phase. And 2015, we actually managed to establish ourselves to join the elimination phase for human malaria. And along the line, we actually come up with various documents, and it's actually available online. But I would like to make everyone pay attention to this particular document, which is actually published in 2017, whereby that is the start of our Malaysia stratification program, how we stratify our cases, especially on human malaria. And at the same time, during this period, we have a few programs that is developing as well. Besides detecting genetic cases, we also develop our online system, which we call eReco Online. That's where all our malaria data is being registered for all parts of the country into our mainframe in Kuala Lumpur. So by 2018, we actually started to have 0 indigenous malaria cases, and after 3 years, we are right now moving into the prevention of malaria reintroduction phase. So with this, at this moment, the stratification of human malaria become very, very important as we move into the POR phase of human malaria. So in definition, what is the meaning by surveillance? Surveillance is actually an ongoing collection of data, and we need to analyze and interpret the data so that we can make an impactful implementation and also evaluation for all our strategies that we want to do. That is in a nutshell of what is the importance of surveillance data. So for regards to stratification for Malaysia, we actually appreciate 4 components. First of all, as mentioned earlier, the importance of data and surveillance, the epidemiology that happen around us, and how to implement strategies to actually curb the outbreak and also prevent the occurrence of malaria in Malaysia. And fourth, the most important one is the multi-centered collaboration between the medical doctor, the entomologist, the health personnel on the field, as well as other agencies that we actually bring along to help us to develop softwares and also programs catering for our Malaysian needs. So for stratification of malaria in Malaysia, we actually need to focus on transmission intensity, as well as because right now we have a very low disease burden, so we actually focus on malaria foci, the localities per se. So as we progress along, we have to identify the localities rather than the places. And we also develop what we call a malaria genetic potential. So that's what that 2017 guideline, the Green Book that I mentioned earlier. Basically, we actually specify everything in this malaria genetic potential. So the disease stratification is the starting point for our malaria elimination program. And we actually look at all the high transmission settings. So we actually map them together, and the data is collected weekly and monthly. But most of the cases right now is the day-to-day basis into the mainframe. And also we develop stratification based on the geographic needs of the local area. As mentioned earlier, we have moved away from API because our cases is very, very small at the moment, and mainly are all imported cases. And the stratification is based on what we mentioned earlier about the guidelines, and we actually stratify our cases based on 2 things. One is the receptivity and the vulnerability. Receptivity meaning to say the data from the vector, and also from the entomology, as well as the exposed human under the vulnerability component. So the 2016 guideline is the particular green document that I mentioned earlier, which is available online. This slide actually shows the involvement of the program in Malaysia. That's been our malaria program. So with the movement from the pre-elimination phase to elimination phase, our API indexes also start to change. So initially we were talking about district, then we move on to sub-district, and right now we move to locality, and even further now to malaria genetic potential. So when it comes to epidemiology of the human malaria, as described in the graph, we actually have very, very low disease burden of human malaria cases, and we have really started to report new indigenous cases in 2018. And since 2008, when we developed our PCR capacity, we start to detect significant numbers of genetic malaria, and these are our interest trends. And due to the recent COVID pandemic, we do see increased cases due to our MCO, whereby most of our villagers are actually at home, and they conduct their own activities in their villages. Therefore, we have an increased number of cases that in 2013. So this is actually the genetic malaria mortality in terms of the breakdown of the human malaria as well as genetic. And for 2021, as shown here, many of our cases are all imported cases, and we only have 2 indigenous cases back in 2021. Currently, all our mortality cases are actually due to genetic malaria. Altogether, 13 cases over the thousands of cases that we detect from genetic malaria. This is actually a snapshot of the earlier graph, whereby to signify this is actually our current burden of genetic malaria in the area. So for 2021, we actually see decrease in the human malaria cases, but for genetic malaria, we saw a increase in cases due to the fact that most of the villagers are at home at their villages, and they tend to do other activities such as opening farms or orchards, small things in villages, activities done, as well as they move outdoors more frequently as compared to during the non-MCO period. So therefore, most of the genetic malaria vectors are actually outdoor hunters. So most of the cases will actually be seen during the peak hour, and therefore we have a large number of cases reported as compared to 2020. This is actually the breakdown of our cases of malaria. So our burden, as mentioned earlier, are mainly genetic, and we have a small number of virus and antibodies. So with regards to stratification of the human malaria, in Malaysia, we have adopted to classification of our locality. So we divided our cases to active foci, localities to active foci. Any cases that actually found to be reported to have malaria, that particular locality will be known as the active foci for the first year, so in 2018. After the end of that first year, in 2019, for the next subsequent 3 years, we will classify that locality as residual non-active area. So by the fourth year, if there's no other new cases reported from the area, we will call it a cleared foci. So we actually stratify our human malaria cases based on these three definitions. And for clear foci, we also did the metabolic potential, whereby we actually did our stratification in terms of receptivity and vulnerability that I mentioned earlier. How we classify them, I will highlight in the next few slides. So from here, we actually decide whether at the end of the day that particular clear foci has high, medium, or low metabolic potential. So in terms of receptivity, we do appreciate that there are many localities. At the moment right now, we have registered 40,000 and above of cases of localities registered into our mainframe. So our entomologists actually come up with a particular assessment. We call it the initial NSB assessment. In Malay, we call it APEPA, PAKEPA. So it's an ecological assessment for the NSB sector. So on top of that, they also have the entomological risk assessment era, and from there they actually decide out of that 40 over 1,000, then which actually are environment is suitable for the NSB to be and their behaviors to be activated, to be active. So from there, they also use other proxy data, whereby they will take samples from the remaining 30 over 1,000 cases, and they will see, they will reduce that from 10 localities to at least 1, based on the main reason if they have similar geographical endpoints, then they will actually reduce the numbers for their assessment even further, so about 1,000 to 2,000. So the assessment is done routinely, and they will be reported to our ministry from the same online system. So these are the parameters in terms of vulnerability, the expression of the human component. So they are altogether 10 parameters. And this is the receptivity component done by the entomologist. So at times, they might not be entomologists at the field. So therefore, we actually share our resources and we ask our staff to actually assess. And if they can see the parameters, it's actually quite simple for them to assess. And there will be guidance given by entomologists to assist the non-entomological personnel to actually help together this process. So with all that, they are scored, and we have the receptivity and vulnerability code, and they will be put under this matrix. So at the end of the day, any particular dark green is actually be considered as high. We have a score of level 6, medium will be 3 to 5, and low is less than 3. So this is actually the diagram that I mentioned earlier, that after we classify the three main categories, there are actually activities, vector control activities that are need to be performed. And for clear foresight, we have the three components. And the vector control activities within IPN and LI will be focused on high and medium, whereas the low clear foresight will actually just do simple monitoring, and there won't be any surveillance monitoring, and there won't be any vector control activities as compared to the other certificates. So as I mentioned earlier, we have about more than 40,000 localities registered, and at the end of the day, we actually focus about 1,000 to 2,000 localities per day. So most of them are no classification based because of the Pakapa assessment that we did, that I mentioned earlier. This is actually the localities that we give IRS, and these are the ones that we give our LRM answer. And our coverage is about 70 to 100%. And depending on the state, this is where most of the cases that we have challenges. So it could be about 50% in the very low area. So the next one is actually about zoonotic malaria. So a little bit history about how zoonotic malaria been identified. It's actually first reported back in 1927, and one of the scientists came from Dr. Robert Morley, who actually identified this parasite actually in 1932. And 2008, 2004, in Malaysia, we developed a capacity to detect zoonotic malaria. So basically, besides having the NFI mosquito, which actually we know mainly are outdoor biters, in Sabah, the vector is Anopheles bilogacensis, and Sarawak is Anopheles lutein. So besides having that vector, we also have another intermediate host, which is actually the macaques. So we identify two particular macaques that actually are host for the parasite, which is the macaque fascicularis and macaque nemastina, which is actually available in both parts of Malaysia. So the activities that expose the human to when they do their ushers and when they share the environment together with the macaque and with the presence of the vector, therefore the zoonotic malaria is transmitted. So therefore, at this moment, there is yet to be any evidences of human-to-human transmission, mainly the report that the studies that we have conducted so far mention of the spillage of bites from the macaque into the human population because of the sharing of the close proximity between the human and the macaque population. So due to that, since 2008, we actually developed control measures for to handle zoonotic malaria. And we have a document, it's actually in Malay, whereby we also do similar classification in terms of zoonotic malaria. But instead of 3 classifications, we have 2. One is high burden district and low burden sub-district. So any incident cases whereby we report of above 1 to 1,000 population, we will say that this particular locality is actually high burden sub-district. And the low one will be the less than 1 to 1,000 population. So the control measures, the RRS, is actually done for the high burden district. And in Malaysia, we actually have another additional term, we call it outdoor residual spray. So not only we spray indoor, but especially for zoonotic malaria, we actually focus our spraying on outdoor, which I will describe later in the next slide. What do you mean by outdoor residual spray? So when it comes to, once we have already stratified them, so these are the activities that we will conduct. So the ORS actually stands for outdoor residual spray, and we also give LIM to for zoonotic malaria as well. And we actually cover the premise for about 3 days for both LIM as well as ORS. So finally, when we talk about outdoor residual spray, we actually spray outside of the house, including the adjacent plants, and we actually cover minimum 5 meters, maximum about 2 kilometers, bearing in mind that we actually choose 2 kilometers based on the flight range by the vector. But mainly most of the time, the coverage actually carry domestic, which is actually within 5 meters from the house, the house of the index. So that is where we will conduct our control strategy. And besides this, we also have the classification of the source of infection as well. So if the source of the infection is in the middle of the jungle, there won't be any control measures. But similarly to the picture previously, if the source of infection we say that it's quite adjacent to the household, therefore we will choose that particular village to conduct our control strategy. And we also counsel and provide LRI to the individuals, and sometimes they will also bring the LRI into the jungle where they want to conduct certain activities as well. So in conclusion, in Malaysia, we actually developed our certification manual back in 2016, and our certification is based on receptivity and vulnerability, whereby we actually share and integrate most of our resources, especially our dependence on technical advisory for our SMI security. So with that, I end my presentation. Thank you.
Thank you so much, Dr. Tam. Next, I would like to invite Kun Surawadi from DVBD Thailand.
Sorry, my neck is not good. Okay, good morning, สวัสดีค่ะ I'm Surawadi Kijakan from DVBD, Ministry of Public Health Thailand. Today I'm gonna share Thailand experience for stratification technique. My outline is the present on Maria's situation and certification for classify malaria elimination activity that we use case and area to classify intervention packet. And the last one is data quality. This slide show the monthly malaria cases 5 years. You can see that Thailand is quite good on control and reduce the case. But if you see this year, 2022, the case is going up from 3,000 case to 8,000 something case, especially in Thai-Myanmar border. And for stratification of malaria elimination activity, Thailand, we used 2 things. One is malaria case and the second is area. Firstly, I would like to make you understand for case definition for malaria elimination. Every positive malaria case need to be diagnosed and confirmed with laboratory, RDT, microscope, PCR, both symptomatic and asymptomatic. And all confirmed positive case should be in the SOLAN system. Because of this one, under 2015 Infectious Disease Act, malaria is notificable. Then every single case need to report into the system. And we have 2 case finding, one of passive case finding. Every suspect malaria case who visit health facility, both community and health facility, we need to catch up. And also we have active case finding from proactive case detection. We take the blood exam for risk population, and when we have case, we do reactive case detection. We take the blood sample around in the case 50 people or 10 households. This is our case definition in Thailand. We don't have we have only confirmed case. We have no suspected case, and we need to confirm with laboratory. And then when the case are reporting in our system, and all of confirmed malaria case are to be investigated and classified by using investigation form. In investigation form, we collect the data. For example, we have patient information, date of symptom onset, malaria species, and treatment regimen. The important one is history of traveling, and we ask for history for previous malaria episode, and we also ask for location where the patient live and where the patient go. Then all of this one we can classify the case classification into like indigenous or imported case. This is a form that we use quite a lot, information things. This one is like patient information, and then the species and traveling, and this one is a little bit survey on the activity that we did. After that, we can classify into a lot of things, and you see that. For example, A is present that patient infect in the village. Our administrative unit is sub-village or village. Then we classify A as an indigenous and B as an import, but only in country. But if we cannot talk to the other, we can group A, B, X, B, Y, something like this into indigenous because it's infected in country. For import, we only have like this one, BF. It means that the patient infected from other countries, this one. And we also have relapse, introduce, induce, and unclassified. This is a result for malaria classification in 5 years. We can investigate around more than 95% of the total case. And we can, this is a result that we can classify. Almost of them are indigenous and import. And this one, if you see that this is a problem, this is a gap for data quality because of unclassified mean you cannot identify the source of infection. If you cannot identify source of infection, that's a problem. If you see that this year, the current year, the case is going up, right? This one, we have a lot of imported case, and we also have like unclassified case, which is 20% of total case. Another criteria that we stratify is area. We use the criteria for classification as a malaria case, as I told you, especially we use indigenous case or source of infection. And the second criteria is vector present. We have, we collect the primary and secondary malaria vectors, both larva and adults. We collected in our system, and then we use environmental factor, forest free area, and like rubber plantation as a environmental factor. And as I told you, administrative unit of area stratification is sub-village or village. After we use that previous criteria, the fourth criteria, we define our areas into 4 categories. First one, active case, we define as area with the present indigenous case in the current years. If you have indigenous case, you have source of infection in the village, then it's classified as active foci. But if you don't have indigenous case, you have imported case, something, and less than 3 consecutive years, we are defined as a residual non-active foci. And the third one, a clear foci with receptive, the area without indigenous case, the same, but the time is different. At least 3 consecutive years, and present primary and secondary primary or secondary vector, or like environmental is suitable for the vector. We classify as clear foci, but still receptive. And the last one, clear foci without receptive, is mean like here, Bangkok, the area without indigenous case, at least 3 consecutive years and no vectors. Okay, this is the result for area stratification this year. For active foci, actually we have only 0.7% located here, Thai-Myanmar border, and we also have like 0.4% for residual non-active foci. Most of area in Thailand is a clear foci, but 12% are still have mosquito, and around 87% are clear. But if you see the result, this one, if the residual non-active clear foci with receptive and clear foci with non-receptive, they have only single indigenous case, that area should be turned to active foci. For example, we have 129 sub-village of residual non-active foci turn back to active foci this year. This is a serious problem because we classify at clear foci with no mosquito, but we have 34 sub-village have indigenous case and then turn to be active foci. As I told you before, we use case and area to set up the intervention packets. We classify the area as 4, right? A1, A2, B1, B2. And we set up the intervention packet of case detection, PCD, ACD, treatment, follow-up, that only every area need to do it. Surveillance, we apply 137 for all of country, and vector control, we just done only in A1 and A2 areas, same as ACD. And for 137 that we implement in our country, after confirmed malaria cases notified within 1 day, we need to investigate within 3 days. And we use 2 criteria: the area, active foci, residual non-active, receptive, non-receptive, the area, and case classification, indigenous and import, to do the activity. For example, if the patient live in A1 and classify as indigenous cases in that village, the activity that we need to do are this box. We need to do reactive case detection, we need to do vector control, and provide health education. And another example is like, if the patient live in non-reactive, non-receptive, for example, Bangkok, and that patient classified as imported case, maybe he infect from Tak province, what are we gonna do? Nothing for response, but we need to treat that patient with the antimalarial drugs. And actually we need to inform Tak province to do something with this sort of infection. And this is the new one that we developed with the Inform Asia, because we have a problem of the reintroduction. Then we need to make something plan for prevention of reintroduction. We have set up the criteria for risk metric and risk stratification. We use like same as I think Malaysia, no? Receptive, we have R1 and R2. R1 is present malaria vector and environmental suitable for breeding, something like that. And R2 is malaria case, especially indigenous case, at least 5 years. And the second criteria is vulnerability. We have V1 and V2. This one is about like the population movement, and V2 is like for imported case at least 5 years. The result of risk stratification that we need to use, we will use to plan for prevention and reintroduction. We classify as 4 level. Level 1 is local transmission. It seems like active foci, something like that, and resident transmission. And we need to focus these 2, high risk and low risk. The intervention for the 4 level, we're gonna define later, and we are developing the guideline, and we will pilot in the next year. And the last bullet for the data quality. For laboratory, actually they have a lot of activity. I just give you an example. We have cross-check on microscopy, PCR confirmation, and for confirmatory cases, as you know that Thailand has 2 parallel surveillance systems. The one is vertical program and another one is national surveillance system. We need to combine 2 surveillance system into one to come up with number of malaria cases. And we can combine the 2 systems, and we remove the duplicate of number of cases by use fuzzy logic with several variables. For example, name, age, gender, species, something. But unfortunately, fuzzy logic can remove the duplicate of number of malaria cases only 87%, and for 13% we need to look up at like manual check. And for case classification and area stratification, actually we have the meeting annually, officially at the end of fiscal year, October every year, to verify case classification, the sort of infection, the area stratification. But if in case of we confirm new foci, for example, we found the indigenous case in the clear foci, and we are already confirmed that, okay, it's indigenous, and we need to change the activity immediately from clear foci to active foci. Thank you. This is all my presentation.
Thank you very much, Khun Surawadi from DVBD Thailand. Also, thank you for the 2 speakers from LAPTR and also from Malaysia. We received the comments and questions online. So for online participants, we will answer your question in Q&A session after we complete all the presentation. So I think the coffee break is ready for you. All right, so we're gonna have a coffee break for 15 minutes, and then we're gonna continue our presentation next after the coffee break. Thank you. Okay, I can move myself rather than moving the flowers. Thank you. All right, welcome back. So we will have the next speaker from Bangladesh, Dr. Musik. Yes, please.
Okay,
Left slide? Yes.
and this is next
Yes.
slide. Okay.
Only here. Yes.
This is, oh,
Yes.
Honorable Chairperson, Mr. Ratnakshay Firsavan, Honorable Co-Chair, Dr. Richard Maudi, and in Bangladesh Delegate, Director BRAC, CDC and WASH Program, Dr. Akramul Islam, my teacher, Steve Ebner, colleagues from different member countries of Asia Pacific Malaria Elimination Network, Surveillance and Response Working Group. Welcome to my presentation. I am Dr. Mushikur Rahman. I worked as an epidemiologist at National Malaria Elimination Program at Bangladesh CDC. Next slide, please. With few slides, I will share in the titled High Quality Data for Targeted Surveillance Intervention. And first of all, I would share the experience with API tracker, which is developed by a dedicated Moru team worked led by Mr. Sajid at Bangladesh. I will share plan to transition to village level data collection and others. And I will also give a highlights of a recent small project supported by APMEN. And I also will describe some needs from some support from APMEN. First of all, this is a innovative platform which was developed named Malaria API Tracker Monitoring Platform. You know, we have a malaria management information system, and this platform, we have linked it to DHS2, and we linked it to Malaria API Tracker. BRAC, our another peer, worked very closely with malaria elimination program. They have field level worker, and they collect data and using a software named Kobo Toolbox. And we also linked it to this National Malaria Tracker, API Tracker. And also the API tracker has a room for capturing data by SMS system. And this is the outcome which we can produce. First of all, this malaria API tracker can give output as annual parasite incidence map. Here you can see the dynamic map we can produce. Here was malaria cases, deaths, PV, PF, mixed count at Upuzila and district level. We can produce bednet coverage map by this software. We can produce malaria vector map. You can see this is the distribution. We can also map out the health facility and health worker distribution throughout the malaria endemic areas at district and sub-district level. And there is another section where we can produce graphs, yearly malaria cases at sub-district level, deaths at sub-district level. We can analyze age group, we can analyze gender segregation, and we can produce some species-wise graphs, charts, and we can also produce some graph charts regarding case fatality rate at sub-district level. And also we can produce graphs and maps on malaria test, case, and test positivity rate. And what was the difference after using this malaria tracker? You can see the earlier reporting system was manual. Now we can produce a report by customizing, and it can be auto-generated. And overlaying with different layers of data set. Before it was not possible, but it can be done with only data with different administrative units, and data can be generated and downloaded in the form of chart and graph you have already observed. And we can measure the distance now. We can visualize the visualization and monitoring in the maps. And we can also distribution and coverage health worker, as I have already told, which was not available before. We can also yearly malaria cases and severe malaria cases, case fatality rate at Upuji level. Earlier it was manual, and we should produce by using Excel, but now it is auto-generated. Finally, we made access. Earlier it was restricted, but now it can be accessed to all those we permitted there with password and the and the login name. Now I will say the transition to village level data collection. Earlier, you know, our case incidence is gradually slowed down, and we envision to have malaria elimination by 2030. And for that region, we have to go to the village. We have to transition, need transition from aggregate data to individual data. And here, as well as it was also emphasized in global technical strategy as our national strategy as well, that village level mapping of access to identify hotspot for targeting intervention. In this regard, BRAC is collecting data at village level. As I told that they use Kobo toolbox, and a dedicated team I have mentioned, the group mapper team led by Sajid and Moru. They are piloting 604 villages in Lama sub-district, which was a very high burden sub-district of a highest burden district of Bandarban. And we have taken initiative to collect village level data by capacity building of the health workers, both from BRAC as well as government, and developing a user-friendly SMS data collection and with redesigning the existing form. And this is the update. This is a short-term project supported by APMEN, and 10 weeks we have, this is the work plan. We'll do village data preparation. We will produce digital form creation and finalization, and we'll redesign monitoring dashboard. We will provide some training to the health worker. for data collectors, and we'll collect data from that 644 village, and above all, we'll do the monitoring, and we'll finish it by 10 weeks. That is 20th of February, January. We'll complete this task, and if it works, if it have some impact for our ultimate target for transitioning aggregated data to individual data, we will envision to scale up to another sub-district, another high burden sub-district of Bandarbhan, then another high burden sub-district of Bandarbhan, and then we have envisioned that we will complete it in 13 endemic districts. And also by doing this, during doing this, we have felt some challenges regarding data quality and validation, because there are some typos, English, Bengali typos and English, many organization nomenclature of the village name, and village master list. There are some minor discrepancy between data collected by BRAC and data collected by the Moru team, group member team. And actually, there are, throughout, we have actual real-time data is not available, because our sub-district is aggregated data. Our Upazila sub-district statistician is reported at in the high burden district, particularly hill district. They actually provide aggregated data on monthly basis. And regarding health worker, only 50% of the health worker have tabs or Android-like phone. Others not, because malaria is in very remotest places in Bandarbhan district, very hill and very hard to reach area. So these are the challenges we have faced. And of course, we envision that APMEN, we seek technical assistance from APMEN regarding village mapping. As I told, we are piloting at one district, at one sub-district, and it needs to scale up in other sub-district and other sub-district if it works well. We need technical support to establish the malaria elimination database that we need, and it's a elimination requirement. So we seek support to from APMEN regarding this malaria elimination database establishment. And we also seek some technical assistance for malaria case for mobility study, particularly for forest guard, mobile migrant population, and also some GIS-based mapping for cross-border surveillance, because without it, we can't go. We need also, as the director BRAC, Akramul Islam Bhai has advised, that we need private sector mapping as well, private sector surveillance. We need these three broad area support and technical assistance from APMEN. Distinguished audience, you know, Sir Isaac Newton has invented gravitational force by falling of an apple from a tree. But there is a science that it is well established that we can see the gravitational force by falling of an apple. But there is also a science, there is also a force which compel a seed to make a big tree. So we envision for our transition from control to elimination as such, that would be very challenging, that would be very complex, that would be very comprehensive force to reach our target, to reach our surveillance system from aggregated level to the individual level. And that is all from my side. Thank you for your patient sharing. Any question? Okay.
The question will be in
Oh,
Q&A
okay.
session. Yeah, thank you. Thank you so much from the presentation from Dr. Mosik Rahman from National Malaria Elimination Program, Bangladesh. We have next speaker, Dr. Mushtaq Ahmed Said from Vector-borne Disease in the Health Department, Government of Sindh, Pakistan. Please. Yeah, left and right. Yes.
Bismillah ar-Rahman ar-Rahim. Good morning. I want to thanks Dr. Ratnagze and Professor Richard Mord and my malaria director, Dr. Mukhtar in Islamabad. They give me an opportunity to present few slides of a Pakistan problem in front of you. Yeah. This is the outline overview of the malaria data quality for targeted surveillance intervention, challenges faced in a data quality and stratification, experience with transitioning to case-based surveillance, challenges in the implementation of intervention, support needed from the partners. Overview of the malarial API in Pakistan. Pakistan is among us the 6th WHO EMRO region countries with high malaria transmission. About 100%, 225 million of the population living at risk. Cumulative API of Pakistan in 2021 was 1.8. However, province-wise API, likewise Balochistan 11.8, merged area is a 6, and the Sindh 2.7, and the KPK 1.6. They are all in the control phase. And Punjab is 0.1, and Azad Jammu Kashmir in pre-eliminatory phase to ensure the case-based surveillance and strengthening the malaria response. These are the comparison of malarial cases in Pakistan 2021 and 2022 up to January to October. In 2021, there was a 3.4 suspected cases in millions. Among them, 0.17 are the confirmed cases. Now in 2022, up to the October, January to October, 4.7 suspected cases, and among them 0.48 confirmed cases. These uprise due to the observed in the Sindh and Balochistan provinces after the devastating flood in the August 2022. Sindh and Balochistan both account 78% of the confirmed malaria cases. However, in the plasmodium wise, there was a 2021 as a plasmodium vivax was a 77%, and 23% was the plasmodium falciparum. And in the 2022, there was a 82% of Plasmodium vivax and 16% of a Plasmodium falciparum. This is the malaria data quality for the targeted surveillance intervention. We are capturing the quality data like this. Just as I'm showing the example one, capturing of the quality data of vulnerable population to distribute line. For example, in pregnant women, age of under 5 children, and severe malaria cases admitted in the hospital. We faced very much challenges in the accuracy, and there the data was fragmented and paper-based data, timeliness, and completeness. The graph pie chart is showing the 2022 cases found in the IDP camps and the health facilities. There was a 296,231 under 5 children and severe malaria cases in the hospital. There was a 5,190 cases, and the pregnant women in the IDP is a little bit from 13,489 cases. So this is a pie chart. We are capturing this kind of a data, and we are facing these problems in a quality wise. Example number 2 is when we treating the cases in the rural and private setups, and we found that malaria case management in rural and private underprivileged setting due to untrained HR, human resources, and they don't understand the malaria case response, resulting increase in the duration of a disease and ultimately vulnerability amplified. These are the pictures showing the cases we have found in the rural areas. This one is a stratification of Pakistan, stratum 1 and stratum 2 and stratum 3. So in the stratum 1, whereas the API is greater than 5, is 60 districts in the stratum 1, and stratum 2 is a 26 cases, whereas the API is a 1 to 4.9, and the stratum 3 is a API was lesser than the 1, 73 districts. So these are the targeting elimination for the Pakistan and WHO technical strategy malaria stratification developed malaria program review by the WHO. Challenges in the stratification of the data. In the data collection tool, the desired variables are lacking, which hamper the desired data collection. Poor capacity of health care workers to collect the data, and overburden of a healthcare providers, multiple reporting system, insufficient medical entomologists, absence of the management information system, experts and data scientists, no linkages with other line departments, and limited involvement of relevant stakeholders, scarcity in research culture. This is a chart showing the patient flow, mechanism, and case response. When patient comes to the healthcare provider with a suspected malaria and go for the test in the RDT or microscopy, if found negative, then rule out for the malaria. If found the positive, then again return back to the healthcare provider for the medicine and information to the malaria control program. However, in this chart, and this is a mechanism, we found also the challenges. in the manual sharing of reports leads to delay in the data quality. I already yesterday discussed that when we found a positive case and then we received the confirmation within not within 48 hours, but in 1 week or 15 days. So inadequate, unqualified, and untrained HR for the response and case management, limited resources for the vector control intervention, and lack of coordination with the district departments, other departments. Experience and challenges during the case-based malaria surveillance. Manual reporting leads to delay in data collection, timeliness, and completeness, inadequate trained HR, and also inadequate logistics, limited resources for the surveillance activity, lack of the coordination within the inter and intra-district administration, multiple reporting system with no integration along with informal or private healthcare providers. This is a multiple malaria case reporting channels. However, Global Fund is using the DHIS2 up to the national, province, and district-wise, up to the health facility, and the malaria control program is using the national-wise and province, district, and health facility-wise. They both interact with each other. However, the DHIS only, not the DHIS2, DHIS Lady Health Worker Program, management information system also capturing the malaria data of the pregnant women, and the now is a integrated disease surveillance response. So these are the multiple channels. A patient get confused that how can, and also HR healthcare providers also get confused in duplication of the data. Challenges in the intervention and data quality issues, national-wise, province-wise, and district-wise. The inadequate malarial data, limited data quality checks and analysis for disease, trends, outbreaks, detection, and response, inadequate disk validation of the data, limited integration with other information or surveillance system, inadequate coordination with relevant stakeholders, limited feedback from province to district and hospital administration. Health facilities, lack of the written guidelines to fill out the data collection pro forma properly. Behavioral determinants as well, limited information gathering and demographics, clinical features, and risk factors due to inadequate training, stock out. However, just like outpatient registers and logistics also get stock out. So this slide is for the support through the partners that global goal towards the eliminating malaria in the Asia Pacific is a collective concern. Cross-country collaboration for the learning and coordinate action are equally important. Therefore, a capacity building along with research and planning resolution is needed in the local framework. Capacity building in all sections and at all levels. In the case management, integrated vector surveillance, disease surveillance, diagnostic surveillance, and quality assurance, and establishment of a center of excellence for the research and microscopic references, senior level and mid-level managers, training courses and certificates for the malaria elimination strategies. Prior, it was designed by another country, and research and planning, analytical approaches, and other related short courses. Thanks very much.
Thank you so much, Dr. Mushtaq. Next speaker from Solomon Island, Dr. Leonard Boards from National Vector-Borne Disease Control Ministry of Health and Medical Services of Solomon Island. So please. left and right. Yes.
Here's the pointer.
Yeah. Yeah. Click on it. You can click.
Thank you and good morning, everyone. I'm Leonard Boas from Solomon Islands. First of all, I would like to thank APMEN for the invitation to join this annual surveillance and response working group. Now, my presentation will be an overview of the malaria situation in Solomon Islands, and then move on to the data that we collected for, and then move on to how we are looking forward to move on to case-based surveillance. We're still, maybe during my presentation, you might have some, especially partners might have some interest on how to assist the malaria program in Solomon Islands. So this is the current malaria situation in Solomon Islands. We were aiming to reduce the malaria incidence every year, but then we keep on increasing the incidence of malaria in Solomon Islands. So by 2021, we have API of 120 per 1,000 population. Now, if you look at it by provinces, we have around 8 provinces in Solomon Islands. And you can see we have very low malaria in 1 or 3 provinces, and that is Choiseul, Isabel, and probably Western Province. Yeah, so these are the 3 provinces that we are looking forward to roll out this case-based surveillance. But so this stratification we did is from the DHIS2, and it is manually done from the DHIS2. So looking at it, we have this one is Isabel province with very low malaria incidence. And that is the first province we are looking forward to roll out this case-based surveillance. If you look at it, in 1 year, Isabel province will have around 300 to 400 positive cases per year. Yeah. So, and if you look at the number of health facilities by for this province, some clinics, they don't have positive malaria cases within 3 to 4 months. Yeah. And during the period of no cases, there is no report. Yeah. So if you look at the this one, this is the reporting we have for Solomon Islands in 2021. Yeah. So these are the number of total confirmed cases. This is the blue one is those who were negative but were given treatment. Yeah. And the red ones, the red part of the bar graph is there is no test, but treatment were given to the patients. Yeah. So what does this mean? That means either you have stock out of RDTs or anti-malaria drugs. Yeah. So these are the challenges we face in our health system. Yeah. Now reporting itself is done by the nurses, like diagnosis, treatment, reporting. They are all done by the nurses. So the program relies on the reporting of the nurses to be entered into this DHIS2 platform. So if there is no case in one clinic, then there is no report. But we expect a report from those clinics. So probably that is why we have very low reporting rate in Isabel province, because for 2-3 months, they don't have any positive case, so they don't give a report. Yeah. So the country itself has identified Isabel as a province that is the lowest with lowest malaria incidence to do a trial on this 2+7. Now, in I think most of the countries, they have put a 1-3-7 strategy, but because looking at our system, because there will be delays in reporting, yeah, we put it to 2. Yeah, because malaria is not a notifiable disease in Solomon Islands. Yeah, so that is why we put it. We start at, instead of 1, we put it 2. Yeah, so 2+7. And as I have said, there is a big gap in our stock management in the health facilities. Yeah, probably the Global Fund had enough drugs procured for the country, but then at some stages we always run out of drugs. Yeah, so that's one of the big challenges we have in our program. Yet we are still trying to eliminate malaria by 2030. Yeah. So how can we, despite the increasing trend of malaria, hopefully by in the next few years, we can keep reducing the malaria so that we can join all other countries to eliminate malaria by 2030. So the program, in terms of transitioning to a case-based surveillance system for this 2+7, we have discussions with ZIPD. I think the Jiangsu Institute for Parasitic Diseases in China, yeah, to assist us in Isabel. They are planning to conduct operational research in 2 low burden zones. So instead for taking the whole province, we are looking at 2 zones with low incidence, so that we can put a trial on this 2+7. But the Jiangsu Institute is yet to, they already sent us some assistance training on this 137, yeah. But we need to, they are still yet to come to the country to assist us on this training. After the training, we actually have some discussion with the communities in these 2 low burden zones in Isabel province. That's to talk about the importance of malaria diagnosis, malaria case investigation, malaria case classification, treatment, follow-up, and malaria interventions. So we have discussions with the nurses, community leaders, and church leaders. And then we came out with this 2+7 strategy on what we would like to do before day 2, before day 4, and before day 7. So ZIPD had already come up with a budget, but we still have no funders for this budget for the training in Isabel province. So we are still waiting for ZIPD and APMEN and APMEN also assist us get through ZIPD. So still there are a lot of challenges to implement with this project because the DHIS2 does not capture real time data. And the capacity of the health staff zone needs to be improved, and including political and financial support to assist the program with this initiative. And there are some recommendations there on before we roll out that project, because in the country we don't have enough mobile coverage. So we are still talking about giving mobile apps to the health facilities, but then we have to improve the network coverage. And I think China is willing to build around more than 100 towers around the country for these upcoming South Pacific Games. So we are looking forward that when they are installed, then we can move on with this initiative. That is all for my presentation. Thank you.
Thank you so much, Dr. Leonard. Next presentation by Sri Lankan country. So I would like to invite Dr. Samantha Chaya Singha from Anti-Malaria Campaign.
Right. Thank you very much. First, I'd like to thank all the organizing committee and Professor Richard for giving this opportunity. As an eliminated country, it's not working. As an eliminated country, I would like to hold on a minute. I want to categorize this into three phases. This the last indigenous case was in 2012. Then we got the certificate in 2016, and 2021. We have some sustainability issues were taken into account. Right. If we go back in history, we can see that the cases at one time it was very high, and then suddenly it came at one point it was very low, and we thought we were almost eliminating phase, but then suddenly again the cases rise during that period. So before elimination, it was the work of the regional malaria officers who were like district coordinators. Now the country is divided into several districts, and the district coordinators, their dedicated work and the staff which led to this elimination. So after elimination, now there were no indigenous cases, all imported cases, and it was mainly from travelers from endemic countries. And therefore the data collection was actually targeted for on the cases, travelers who came from endemic countries. Right. So now in almost all the cases are endemic cases that we are reported are all imported cases, and we have about 30 to 50 cases per year. And so during this POR phase, we are looking at early detection and prevention of spreading of the disease. So for this, there are two factors that are needed for this. One is the quality of data and a good sound decision-making system. So the quality of data is being monitored by the head office, the anti-malaria campaign head office, by having monthly reviews and special case identification review committee meetings, and holding in-service training programs to improve the quality of data. So unlike in the pre-elimination phase, the quality of data should be much more in the post-elimination phase. But we can do this because the limit of cases that are being reported in the country. Apart from this, we have a technical group comprising of senior consultants and who have experience in managing malaria cases. All cases that are reported are also investigated, and the data quality also established. Now the problem is, how can we continue this work? Because Global Fund, WHO have been assisting us right throughout, but in 2021 marked the ending of the supporting system from the Global Fund. So 2022 we are focusing on how to sustain the program and how to collect all these valuable data. So to speak on this, I invite the Director Anti-Malaria Campaign, Madam Dr. Champa Aluthwira, to talk on the sustainability and issues that we are facing during this period.
Now you can see the current status. 0 indigenous cases and imported cases for the year 2022, 36 numbers up to date, 0 relapses, and no transfusion induced cases up to now. Now, what are the ongoing activities up to date? Training and awareness programs, follow-up activities, parasitological and entomological surveillance activities and researchers, advocacy programs, risk group surveillance, and other review activities carried out to prevent re-establishment of malaria in all the districts. So, next slide. What are the issues and challenges after the elimination? I think you all are trying to get the elimination. So you also will face the challenges now we are facing today. No available funds for us to manage the zero cases level, and only WHO is supporting for the activities, for the training activities, and no other donor agencies. And we are in big issue in procurement of insecticides needed for indoor residual spraying and liquid temphos, and promotion of environmentally friendly vector control methods is also underway. And we need L-lions, impregnated nets, especially for the northern and eastern part of the country. Current supply is insufficient for the next 2 years also. So we need at least 25,000 LLINs to be used within next 2 years. And the other things, reagents for the laboratory, reagents for doing PCR and reagents for staining. And actually we have to improve the quality of lab and the other equipment as well, but restricted proactive entomological surveillance due to fuel crisis and due to financial crisis. Government of Sri Lanka is unable to allocate the funds to maintain the prevention of re-establishment phase of malaria. So I think all of these are the threat to maintaining prevention of re-establishment of malaria. So I earnestly request you to support us in this situation. Otherwise, we will get back to previous stages. Thank you all.
Thank you. Thank you so much, Dr. Samantha and Dr. Champa. Thanks so much. So, and now we're gonna have the Q&A session. So I would like all the speakers from Dr. Musik, Dr. Mushtaq, who else? Dr. Samantha, please come back to me again. Dr. Champa, right. And also Dr. Gabupapon, please, all the speakers. So we are going to have the Q&A session. And also Dr. Leonard, yes. Do I miss anyone? I don't think so. Please step up on the stage. And for online participants, we already collected your questions, and then we will pass to our speakers. Also, Kun Suravadi, I'm so sorry. Almost forgot you. And from MOH Malaysia, Dr. Tam, please stay with us.
Yeah, I'm here.
Thank you.
Dr. Tam, can you put on your camera and unmute just in preparation? Okay, so we're going to follow the same format as the previous Q&A. If you have a question in the room, please raise your hand. And if you're online, please raise your virtual hand if you want to speak, or type in the chat and we'll read it out for you. So the room first, starting Dr. Pauly.
Good morning. I have one or two questions to two countries. My name is Pauly from Cambodia. I'm from National Malaria Control Program. I have one question to Laos and one question to Thailand. Regarding to Thailand, I saw in your presentation in the increased number of the indigenous case. And also the imported case is also increased in 2022. I was wondering that what and why is increase of indigenous case, and is there any correlation between indigenous and imported case of the increase of malaria? And the second question to Laos, I would like to know about the stratification, frequency of stratification. Is it yearly stratification or what? How many year or month for the stratification? And is there any intervention for the malaria along the border? Because I observe from your presentation there are malaria case a lot in the southern part of the Lao PDR, especially border with Cambodia and Vietnam. So for the future or for the intervention for the malaria elimination, do you have any cross-border activity for this, the malaria burden? Thank you.
Okay, thank you for the question, Dr. Poli. As I mentioned, the case in 2022 were increased, especially in Thai-Myanmar border. And for our data in MIS database show that both indigenous case and imported case are going up. It may be because of the situation in the another side, Myanmar. The data said that the malaria patient, especially migrant to cross-border migrant, a lot of migrant are infected, and then they will bring some imported case first, and then because of the case is going up, we cannot catch up the secondary generation, and then for imported case, it make the indigenous case make a local transmission happen, especially in Park province. Yeah, and another thing is like because of they are migrant too, we cannot classify the sort of infection of them. Yeah, I think that's the data show us.
Thank you for Cambodia to have the question. It's nice question. From Laos, we set up stratification every 2 years according to by recommendation from WHO, and we have TWG to work together for the set up stratification. And about the border Cambodia and Vietnam, we have intervention if burden reduction area, we surveillance the outbreak. If one case and that area, we respond the ACD in members' household plus history traveling. If that's village nearly border or outbreak about the 4 cases or more than 4 cases, our team respond the ACD in the village at least 85%. Also, we surveillance the TS like a therapy efficacy study nearly border because the protocol for TES we conduct moderate transmission. We should follow up the efficacy the therapy, and also if border have the district elimination, we have 137 to respond. And then nearly border if village depend on strata 3 or 4, we had the packet to implementation like testing treatment provide the long lasting net or hammock net or response outbreak if occur at that area. This is we surveillance like this. Yes, thank you.
Okay, should we move to online question? Oh, Dr. Tang, sorry.
Okay, so thank you very much for very meaningful presentation from different countries. I learned a lot from your experiences. So I have one question for Lao. I don't know if I misunderstand, but I saw in your presentations, when you make the stratification, you have 4 stratum, right? Strata 1, 2, and 3, 4. But for the intervention, you have only 2 packages. You have one for stratum 1 and 2, and you have the second intervention package for stratum 3 and 4. So my question is, why you stratify by 4, but you have only 2 intervention? Yeah, this for Laos. And the second for Malaysia, I saw you have very good progress in terms of human malaria. But for the zoonotic malaria, I mean no-reside, is increasing recently. So what's the reason? And do you have a specific intervention for that increase? The third one, I would like to know more clear in Thailand. You have also unclassified cases. So what's the intervention for unclassified? Yeah, because it depends on if you in this unit you have to do case investigation and for site response, and for the imported you have case management. But for unclassified, then what you do with that? Yeah, so I just have the 3 questions for 3 countries. Thank you very much.
Thank you so much from representative from Vietnam. About the stratification, for the strata, we have the 4 strata health facility catchment area. Strata 1 and strata 2, we intervention package like testing, treatment, and IEC. But strata 3 and 4, we have intervention package like test, treat, IEC, long-lasting net or hammock net, and investigate when outbreak. And we have the entomo surveillance or use the IIS sometime. 3 and 4 intervention packet we implementation like this, but 1 and 2 is low case, 1 malaria free, 2 less than 5 case, but we continue to surveillance also because we concerned the 2 nearly 3 if our population cross to 3 form 2 or 2 form 3, we concerned that they carry parasite, and then we have the intervention packet testing, treat, and IEC in the 2 and 1. Yes, this is our activity implementation according to STATA.
I just want to ask you why you have to share 35 by 4, but you have only 2 packages. So for me, I think I just certify by 2 because you know different in terms of the certification intervention. You have term 1, you have the intervention is testing and treatment. So term 2 also testing and treatment, and it's the same. And 3 and 4, you have the same intervention. Yeah. So my question is, can we only stratify by 2 because there's no difference in terms of the intervention? You understand my question?
Okay, I try. Because we set up like depend on case, right? 3 and 4, the case we call moderate risk and high risk. Intervention packet we set up like this, and if outbreak 2, 4, 3 and 4, we respond. We have ACD in member household and ACD at least ACD in the village. We surveillance like this. We act more like this, but different 1 and 2. 1 and 2 only testing, treatment, and IEC, but we surveillance 3 and 4 like intervention I present follow our activity because 3 and 4 we want to know the main vector. We provide the LIN. Sometimes if high case, we use the IRS because 4 and 3 the similar the intervention packet. Only we set up when outbreak, we respond at more additional more.
You had 3 questions, Dr. Tang. Would you like answers to your other 2? You had 3 questions, didn't you? Can you put your microphone on? Sorry, they can hear.
So for Malaysia, you do very good in control elimination activity. So for the human malaria, it's very good progress. But for the monkey malaria, knowledge is increasing recently. So the question is, what is the reason? And do you have a specific intervention for the event? Yeah.
Yeah, thank you, Doctor. For the first part is actually why the increase these 2 years. We noticed the trend is actually consistent with the effects of the pandemic, whereby there's a large population of people due to the movement restriction order. Individuals who used to be working in the town areas have been moved back to the villages, and therefore they have moved into other industries, opening up their lands, and therefore when they are doing the activities, even at dusk, they are actually exposed to the parabensis vectors. So therefore they are exposed, including the children as well, those who actually return from universities they still have online classes. So therefore, they are being exposed and beaten when they are studying outside to look for internet coverage. So these are the two main reasons that we saw that happened during the pandemic with the increase in cases. With regards to control measures, because due to the lack of time, actually we have ITN and LRN to be distributed to the villages as well. And therefore, we actually changed the strategy to do spraying outdoors with a longer lasting doftamercrin-based insecticide. So we also have other projects that we are considering, including giving the insecticide clothing as well to our certain personnel, especially our military personnel. So therefore, at the moment, we are still in the pilot stages. So therefore, we are still at the initial stages of doing this new strategy. So we are actually open for any recommendation or any ideas to help us to give new projects so that we can actually develop the zoonotic control further. But mainly right now, we are actually focusing on the control strategy. Thank you.
Great, thank you. So we're going to move to some online questions, which are behind just quickly. Sorry, just in the interest of time to give everyone a chance to respond. There's a long list of questions we're getting, and we're going to be sending them out and asking people to respond in writing later after the end of the meeting, just so we can move to lunch. And unless you want to answer very quickly, are you ready?
Okay. Thank you for the question. Actually, we don't have like a specific activity for unclassified case, because unclassified is mean that we don't know source of infection, right? But we can do things like, actually we assume unclassified as indigenous case, but we can do the response activity to the where is the patient living. For example, but depend on the area stratification, because we cannot do the response to the source of infection. Then we do the response with the patient address instead. And for actually for subnational verification, if the province have unclassified cases, we assume that unclassified cases is indigenous case. Then the answer is like, okay, we do respond as an indigenous case.
Thank you for that. So the questions from online are actually behind you. Apologies. The first one is Bangladesh, which is quite a long question about surveillance for incidents in pregnant women. So how do you get malaria incidence data from target groups such as pregnant women? Are all pregnant women tested? Do you also collect data on complications experienced in this group living in high API areas? It mentions Balochistan, which is actually in Pakistan. So if you want to respond,
Yeah. Is a question for me, how do you get malaria incidence data from the target groups such as a pregnant women? Yes, we have a system. It is a paper-based and on an Excel sheets, and we have a network of health facilities and HR over there in a basic health unit and rural setups. So we can get data from the IDPs and health facilities for the collection and give them a proper treatment and intervention if they have a positive case of malaria in a pregnant woman. But my concern is that we need just a IT-based and web-based program for this, because this paper-based and Excel-based data collection get delay in the interventions and treatments, like in Sindh and in the Balochistan. But we have a capacity to cope up the situation. But we are going to establish and we want to support from the partners in the capacity building, and we are going to in a locally web-based dashboard and some like that. So hope that we will fasten this process very soon. But you know, and that the flood situation in the Pakistan, Sindh, especially Balochistan, get worst situation, and IDPs, internally displaced population over there due to the flood. So this makes a crisis over there, and we need a strong surveillance system. That's why we are saying, but we have a capacity to collect the data, but it's going to be delayed. Thank you.
Thank you. A question for Sri Lanka.
Yeah, this is regarding, we have 30, actually it's 36 cases in the country that was reported, and the criteria for classifying them as imported. Now, imported cases is mainly due to travel, but travel history alone is not, we don't take into consideration, because travel history even after 1 year, you can get malaria, especially the species of ovale. But with other parasitological evidence like surveys around, also we consider them for the classification.
Thank you. And a final question for the Solomon Islands. So it's, if the question is if API is shown 360 and in one region is shown low, what is the reason due to good coverage in providing all services or any special initiative taken?
Thank you. I think if you look at the malaria incidence by province, I think it's really due to the program management at the provincial levels. I think that's one of the main factors. And human behavior is also a big problem in some of the provinces. Now, that 360 API is nearby to 3 other provinces where there is a lot of mobilities between those 4 provinces, especially between Central Islands Province, the Honiara City, Guadalcanal, and Malaita Province. So we have a lot of daily movement between those 4 provinces every year. So I think that's where we have this malaria transmission in the central part of the Solomons. So outside the Solomons, we have Isabel. Isabel has been reducing its malaria incidence for a long time, more than since 2015, and it has never been increased to very high levels. So I think it's mainly due to the behavior of the people in the provinces. Thank you.
Thank you. Thank you to all the speakers. I'd like to give another round of applause.
Just I want to Richard, one
Is it-
request in
Yes.
getting opportunity of this platform. I'm requesting to my partners, but especially to the Global Fund, that and due to the next year funding, they are supporting us in 60 districts in Pakistan, especially in 8 districts in Sindh and 26 districts in Balochistan. But we want overall the districts be supported by the Global Fund in Balochistan and Sindh, and especially APMEN for the surveillance and make a capacity building. For this one is a request from my side from the Pakistan and Sindh Balochistan. Thank you very much.
Thank you. A round of applause for our speakers, please. So we'd like to present each of you with a small token of appreciation. We're taking the trouble to come and present. So one at a time. So I'm going to ask each of you to come down from the stage and we'll take a picture, take a photograph. So we're going to cut the last session to keep it very short, but we're going to make a quick announcement first. So this is Dr. Rapipan Mord, my wife, but she's also an infectious disease physician in Thailand. So
yeah. Sir, I just heard this morning that one of our participants got COVID-19. She basically wore mask all the time. I cannot tell who she is, but I have an arrangement with my hospital. I'm working in medical schools or in Ramathipati Hospital, Mahidol University. If any one of you would like to get tested, that can be done. Also, if you would like to go to Bamrungrad Hospital, where I work as a part-time doctor, you can just let our team know. We can just register for you, just use your passport. My nurse can do that, and then you don't need to see me afterwards. Then you will use my order to do the ATK swab, and we use FIA. It takes about 1 hour if anyone wants the certificate, but we're quite sure that that person wore mask most times. So if you need anything, just contact them, these three, and then I can arrange anything for you. Maybe Bamrungrad might be best for you in terms of it's the international hospital, and we will cover all the cost for that, and we arrange transportation as well.
I would like to add a little bit. We also prepare the ATK for you outside. If you would like to test it yourself, you can do it after the meeting. So this one we already prepared for you. And also if the ATK test negative, and if you, okay, I'm sure that I can travel back safely home, there are also another options. They have the ATK and RT-PCR center, the test center at the Suvarnabhumi airport as well. You can like test that. You take like 1 or 3 hours, wait for the result, and then you get certificate, and then you can fly home safely.
thank you. Okay, last session. The future of this working group, which is talking about the next 2 years. And the slides are not moving. Okay, so we have our top 5 research priorities, which we went over yesterday. We have feedback on our tech talks, and everybody seems to like the tech talks, at least those people who attended, and lots of suggestions for new topics. We have great feedback on the training, so most people seem to like the training, and we have a list of suggestions for different training topics to take forwards. We have a lot of good feedback on the newsletter as well, and that's going to continue with a monthly newsletter open to anyone with the same structure, including APMEN partner activities that people can contribute. And then we have suggestions for the work plan for the next 2 years from Mentimeter, including support for collaborative research, more presentations on research projects, and more coordination and sharing between countries, potentially field visits supported through APMEN for countries to learn about each other's surveillance activities, some interest in data sharing, and help with mobilizing resources from donors. So our next steps are, we're going to summarize this meeting as a report, which we'll share back with you. We're planning a publication on some of the content from the meeting, same as we did last year. We will be having a separate breakout meeting at a different day to refine and disseminate these research priorities. So we'll be refining them first and then sharing them with donors and others. We are also using all of the feedback and information from the meeting, including the last set of talks, to develop our updated work plan for the next 2 years, and that will be shared out with the participants. So thank you very much.
Thank you very much. Thanks so much for the speakers, and also Professor Richard, and also Dr. Rapipan for your advice regarding the COVID-19 situation. And we come to the end of our meeting here in Bangkok. So I would like to invite Dr. Ratanasai Peswan, our chair, would provide a closing remark.
Thank you, MCs. So on behalf of the APMENs, SRWGs, I myself and my co-chair, Professor Richard Moth, we would like to express our sincere thanks to all of you for your participation during these 2 full days meetings. So colleagues, lady and gentlemen, please join me in celebrating the success of our meeting proceedings and discussions for this year, 2022, during which we have committed to our themes of strengthening national malaria control programs, especially on the field of surveillance and response through defining data needs for the malaria eliminations. Yesterday, we have heard about Dr. Laura Dessens and Molly Robertson's, clarify significant reporting metrics from WHO and the Global Funds, highlighting the importance of data quality assessments as countries adopt the surveillance system when transitioning to nations. We were provided with the opportunity to discuss these metrics together during our panel discussions and take a deeper dive into discussing potential solutions and partnerships that could address the remaining challenge in various data quality dimensions. The latter could only be achieved when we understand what support is available to all of us. We thank Elijah Philip for discussing the type of support SHI could provide to countries that want to perform surveillance assessments, sharing concrete examples where SHI has supported the data quality assessment efforts in various GMS countries. Furthermore, we are delighted to highlight our commitments toward cross-regional collaborations through a partnership with the RBM surveillance, monitoring, and evaluation reference groups, or SMERGs. Yesterday, Hannah Evo's shared findings from the SMERGs, surveillance practice, and data quality landscaping and consolidation of data quality projects across the world. With your contributions, we are excited to capture more projects in Asia Pacific than currently represented in the trackers, with hopes of using this knowledge sharing platform to identify potential special interests, networks, and partnerships on data quality projects. Colleagues, ladies and gentlemen, this morning we heard about adaptive and innovative ways in which our fellow national malaria control programs have designed the surveillance and response interventions. Data quality emerged as a key to successful implementations in many of these contexts. And I am thankful to all my dear colleagues, Dr. Kebupapon Chindavongsa from Laos, Dr. Tam Cheng, Dr. Leonard Boas, Dr. Muzikia Rahman, and Dr. representative from the vector-borne bureaus for contributing to highlighting these key priorities for eliminations. This year, in addition to jointly adopting the regional research priorities list, we also outline concrete steps to developing partnerships to address these research questions. An evaluation of activities delivered in the previous years and review of potential future initiatives found a need to recalibrate and package many of our ongoing activities, from our monthly newsletters to technical webinars to training workshops as driver for targeting direct technical support initiative for our national malaria control programs. Design of UG is still an evolving mechanism for driving collaborations, and with your feedbacks, we will continue to evolve so that the network may contribute meaningfully to your respective elimination efforts. Ladies, colleagues, ladies and gentlemen, I would also like to extend my sincere thanks to APMEN and APMEN, represented by Amita Chebi and Dr. Sathak Das, who are with us today, for the support towards strengthening of our collegiate forum with our strong network for knowledge sharing and communications. Aboard of our strengths and challenge, the fight and we hope that by sharing our experience with one another, we can identify instances where certain strategies have been worked out, but maybe others we need to improve in order to reach our future targets. And lastly, colleagues, ladies and gentlemen, I hope that with your presence and contribution for these biannual meetings for the year 2022, it's a great honor for me and also my co-chair, Professor Richard North, to declare the annual meetings of the surveillance and response groups officially closed. And taking these opportunities, I would like to wish you, for those who travel back to your home countries, a safe trip and be safe of COVID-19. I do strongly believe that all of us will be free of COVID-19, even though we share our 1.5 day together and soiree together, but we are strong, like we are struggling malaria, as well as we will be able to overcome COVID-19. So have a safe trip back home, and taking these opportunities that the New Year's will be coming. So may I take this auspicious occasion to wish on you happiness and a lot of progress in your futures malaria control programs. I hope that in the coming years we will hear more positive outcomes from your activities, especially in your countries, with all of us will contributed to the common targets to eliminate malaria by 2030. So thank you very much.
Thank you very much, Dr. Ratanasai. So we sure do about the COVID-19. We would like to give you the thank you gift. So Professor Richard and
also have a small gift for somebody very important that's organized this meeting, that spent the last God knows how many weeks doing nothing but Marina, would you step forwards, please? And we have Sartak Das, who's online from APMEN, hopefully just able to see us and hear us.
Yes, I can.
Great.
Can you hear me?
We can hear you very loud and clear.
All right. All right. Thank you. I know this is the worst slot probably to be in, but I will keep my comments very brief. Firstly, Honorable Director General Dr. Ratana Sai, Professor Maud, thank you for inviting me to provide some very brief remarks at the end. And I want to acknowledge all the distinguished colleagues from the national programs in the broader malaria community in the room. After meeting with Professor Maud some weeks ago, you know what, I think we shared the same view that it is important to let everyone in that room know, first of all, that I wished very much to be in person. Unfortunately, I was unable to due to other travel, firstly. And secondly, please don't take that as a sign that somehow APLMA doesn't understand the value importance of APMEN, or for that matter, this working group. I think it's very important to stress that the Asia Pacific Leaders Malaria Alliance is built upon the foundation of evidence and of the technical expertise that sits within the very room that I'm speaking to now. And that is not lost at all on APLMA. And our advocacy will only be as effective as not just the working groups, but the community of technical experts working. I want to just say three quick things in response. And having had the chance to join for parts of the meeting today and been briefed on the meetings yesterday, I just wanted to say 3 points. And I'm going to just do a little screen share, and some of you may have seen this before because it's a favorite of mine. But the three things that I want to say are, first, it is wholly appreciated and understood all the incredible work that is going on within the surveillance working group and more broadly in the countries that presented as we near elimination. But it's extraordinarily important, first and foremost, for me to also stress that, please, I hope we can all not forget those geographies within our region that remain areas which have significant burden of malaria, which still need to move from control to elimination. And I think the Surveillance and Response Working Group plays a critical role in those countries. I was just taking a quick look at some of the advanced data that will be coming out in the World Malaria Report and discussing it with some of my colleagues. And we're still, while it's a 71% reduction in deaths, if you look at Sierra and Wipro, we're still looking at 11,600 deaths estimated, and that's not including Afghanistan and Pakistan. So if that's 31 deaths in a day, that's not acceptable. And I think that in 2022, moving into 2023, it's absolutely unethical and unacceptable that that's the case. And we all know that that is a function of resources. But if there is something that a group like this, APMEN, and certainly the Surveillance Working Group can do, is ensure that the great wealth of knowledge that exists in that room can move to the second point. So my first point is, let's not forget high transmission, high burden countries and sub-regions in Asia Pacific, because we're in this together and we're not getting to elimination until we've eliminated malaria everywhere, as we all know. Prevention of reintroduction is not something that becomes easier. So that's number one. Number one is the high burden issue. Number two is capacity building. And this takes me to this analogy of root bridges, which I'm quite fond of. And that is just to say that we all know that the only way, the only pathway to lasting change is going to be the solutions that are a marriage. And this holds true for surveillance. This holds true for a number of other areas, that it will only happen when it's a marriage between the best of what we know in terms of what works in the evidence base, married with what works for the place. And those of you who aren't familiar with root bridges could take 50 years, 100 years, 150 years. This particular root bridge is from Meghalaya. But when these trees are trained to grow across a body of water, and then over time they become as strong, if not stronger, than concrete and steel. And I think that's part of what the knowledge sharing platform is about. It's about ensuring at the end of the day, and I think this is the commitment of all of us, is that whatever operational research takes place, whatever research takes place, ultimately the point of it is to ensure that it results in something that endures in the countries where we're trying to end something that should have ended a long time ago. And we certainly know we have the tools to end it. And then the last thing I'll say in terms of practical terms is around funding. And I know that this has been something that has been quite an important theme of these proceedings. I know that there is a lot of concern around funding and the Global Fund funding in a number of parts of our region. When we do advocacy work globally, we often face this narrative that Asia Pacific, it's only represents perhaps 2 to 3% of the global burden. It doesn't justify, save, of course, for the RIE, the investment of additional resources. And I think that, please, I would say to this group, it's not lost on us that there needs to be continued advocacy around the fact that getting those last pockets are the most difficult ones, and sustained financing is critical. And if I could leave with one last plea as the working group closes and thinks about the future meetings, one of the things that we need to be able to do is capture how surveillance benefits strengthening the overall health system, how surveillance in malaria can be disaggregated and thought about in terms of ways in which it not only benefits efforts at malaria elimination, but also benefits pandemic preparedness. Those are the kinds of messages that we need facts. We need ways in which to articulate so that we can continue to build the case for sustained investment. So thank you all for tolerating a zoomed in series of comments at the end of 2 days of what sounds like were excellent proceedings. And thank you so much for the continued partnership. Back over to you, Professor Maud.
Thank you, Sartak, and wonderful to have that support. So the meeting is finished. It is now time for lunch. Lunch is on the first floor. Same place as yesterday.